Have you ever stopped to think about how you'd measure something that's literally invisible? I mean, think about it. Break a bone, an X-ray shows the exact fracture. Get an infection, a quick blood test pinpoints the precise bacteria. But pain. Pain is kind of the ultimate paradox. It's this deeply visceral, terrifyingly real experience for you when you're feeling it, but it's 100% invisible to everyone else around you. And as you can imagine, that poses a massive challenge for both psychology and medicine.
And to show you just how complex this whole thing gets, let's look at a true medical anomaly, phantom limb pain, or PLP. This is a condition where someone who has lost an arm or a leg continues to experience severe, sometimes excruciating pain, as if it's coming from the limb that isn't even there anymore. It completely proves that pain is not just some simple physical reflex happening right at the site of an injury. It's way deeper than that, and it really sets the stage for one of the most fascinating mind-body connections we know of.
So, welcome to this explainer. Today, we're diving straight into this invisible puzzle. We're going to decode exactly how we feel, how we attempt to measure, and ultimately how we treat the incredibly complex, subjective phenomenon of pain.
Here's our roadmap for today. First, we'll look at the nature of pain. Then we'll dive into the gate control theory. After that, we'll cover measuring the invisible, explore the pediatric pain gap, and wrap up with managing and controlling pain.
All right, let's jump right into Section 1, the nature of pain.
Before we get into the really mind-bending psychology stuff, we need to lay down the two fundamental categories of pain we're dealing with. First up, acute pain. Think of this as your body's evolutionary alarm system. It comes on fast, it usually doesn't last too long, and it has a very specific, identifiable source, like slicing your finger or rolling your ankle. But then you have chronic pain. This is essentially the alarm system misfiring long-term. It sticks around, it's stubbornly resistant to treatment, and it often develops from untreated acute pain or chronic illnesses. It's a really tough condition that can just absolutely devastate a person's quality of life.
So how do we fix a broken alarm? Well, let's go back to phantom limb pain for a second. There's this wild case study from 2004 by MacLachlan and his colleagues. They followed a 32-year-old guy named Alan who had his lower leg amputated. Alan developed severe phantom pain. He literally felt like his missing toes were tightly crossed and violently cramping. Meds didn't work, electrical stimulation didn't work. So they tried something called mirror treatment. They placed a mirror right down the middle of his body, so the reflection of his intact leg made it look to his brain like he had two perfectly healthy legs. He did exercises while watching this reflection, and the result? In just 3 weeks, by essentially tricking his visual cortex, his phantom pain dropped all the way to a 0 and his stump pain to a 1. He actually uncrossed his phantom toes in his mind. Alan's amazing story forces us to shift our focus from the what of pain to the how.
Which brings us perfectly to Section 2, the gate control theory.
For the longest time, science relied on this old idea called the specificity theory, proposed way back in 1895. The thinking was that we had this separate sensory system just for pain, acting kind of like a direct, uninterrupted wire straight to the brain. You touch a hot stove, the alarm rings directly in your head. But, well, that completely fails to explain Alan's phantom pain, right? So, in 1965, Melzack and Wall came up with the gate control theory. They argued that there is no direct wire. Instead, there's a literal gate in the spinal cord that either blocks pain signals entirely or lets them through to the brain. And here's the real kicker. This gate is heavily influenced by our emotional state and our expectations.
Picture this gating mechanism, which happens in an area of the spinal cord called the dorsal horn, like a bouncer at a really exclusive nightclub. Small nerve fibers carry the pain signals, and they're constantly trying to get in. But large nerve fibers carry normal touch sensations. Think about it. If you stub your toe, what's the very first thing you naturally do? You rub it. By rubbing it, you are firing up those large touch fibers. The bouncer sees these large fibers and uses them to actively block the small pain fibers. You are literally closing the gate to your brain. That is exactly why rubbing a bumped elbow actually makes it feel better.
Moving right along to Section 3, measuring the invisible.
If pain is managed by this mental gate that's swayed by our emotions, how in the world do doctors actually quantify it? Well, they kind of have to start by just asking you. We use subjective measures. Doctors often use clinical interviews, guided by the acronym ACTUP. They ask about your activities, your coping mechanisms, what you think about the pain, if you're upset, and how people are responding to you. Another major tool is the McGill Pain Questionnaire. It's a pretty incredible document with 78 specific words grouped into categories. A patient picks words like flickering, sharp, or searing for the physical side of things, and words like terrifying or wretched for the emotional side. It gives the clinician a total, quantifiable score from 0 to 78.
But as you can guess, just asking isn't always enough. We also have tools like the Visual Analog Scale, or VAS. It's brilliantly simple. It's literally just a 100-millimeter horizontal line ranging from no pain to severe intolerable pain. You just draw a mark on the line and the doctor measures it with a ruler. Quick, easy, and gives a solid number. But then contrast that with something like the UAB Pain Behavior Scale. This one doesn't rely on the patient's word at all. It's an observational tool. Nurses or doctors watch for outward signs, like verbal complaints, how much downtime you need, if you're limping, or even just noticing facial grimaces. It's a really fascinating way to measure the invisible by looking closely for its physical footprints.
Let's turn to Section 4, the pediatric pain gap. So, everything we just talked about brings up a massive, systematic flaw in the field. What happens when the patient literally doesn't have the vocabulary to fill out a complex 78-word questionnaire, or the cognitive ability to mark a 100-millimeter line? We're talking about kids. To bridge this gap, doctors rely on specialized tools like the FACES Pain Rating Scale Revised. It uses 6 cartoon faces showing increasing levels of distress, which is a great workaround for kids aged 3 to 8. But a landmark 2016 study by Brudvik and colleagues in a Norwegian emergency room revealed a deeply concerning problem with how we actually perceive a child's pain.
The crucial takeaway is all in the data from that study. The researchers looked at 243 children and found this massive empathy gap. When assessing the exact same injury using a standard 0 to 10 scale, the doctors rated the child's mean pain at a 2.3. But the children? They rated their own pain significantly higher, at a 3.2. And the parents? They rated it the highest of all, at a 5.5. Emergency room physicians were consistently and significantly underestimating the kids' pain compared to what both the kids and the parents were saying. And the reason this matters is pretty staggering. Because of this gap, painkillers were given to only 14.3% of the children who were suffering from what the child themselves rated as severe pain. Measuring the invisible is incredibly tough, and our own inherent biases can unfortunately leave vulnerable people undertreated.
All right, final part. Section 5. Managing and controlling pain. Once we actually understand and measure the pain, how do we treat it? The first line of defense is usually biological. We use analgesics. These break down into NSAIDs, which are your basic over-the-counter pills that work by reducing prostaglandins, the actual substances causing the pain, and opioids, which are much stronger and literally attached to receptors in your brain to block pain signals directly. But there are also alternative treatments out there. Take acupuncture, the ancient Asian practice of inserting fine needles into the skin. Modern psychology theorizes that it actually works by triggering the release of endorphins, which are your body's natural, built-in painkillers. We can also use cool technology like TENS machines. That stands for transcutaneous electrical nerve stimulation. This is basically a manual hack for the gait control theory. The machine uses little electrodes to deliver a mild, tingling electrical current to wherever it hurts. That tingling sensation activates those large nerve fibers we talked about earlier. It acts exactly like our club bouncer, closing the gate on the pain signals while pumping up your endorphin production at the exact same time.
But remember, that gait isn't just physical. It's highly psychological. And that means we can use cognitive strategies to manage pain without taking a single pill or using a single needle. We're tackling the mind directly here, and we usually focus on 3 main tactics: attention diversion, non-pain imagery, and cognitive redefinition.
Let's look at those first 2. Attention diversion is exactly what it sounds like. You use a stress ball, you do a puzzle, you blast some music. Basically, you're forcing competition for your brain's processing power. You only have so much mental bandwidth, right? So if you fill it up squeezing a stress ball, there's literally less bandwidth available to process the pain. Non-pain imagery takes it a step further. You close your eyes and intensely visualize a calm, relaxing scene. By doing this, you're actually lowering your blood pressure, slowing your breathing, and dropping your heart rate, physically calming down your body's panic response.
The third strategy is cognitive redefinition. This is where you actively replace threatening or scary thoughts about the pain with more rational, positive ones. It usually comes in 2 forms. First, coping statements, which emphasize your ability to tolerate it, like telling yourself, okay, it hurts, but I am in control. And second, reinterpretative statements, which remove the negative associations. You tell yourself, this isn't the worst thing that could happen. You are fundamentally altering how your own brain perceives the threat. It's incredibly powerful stuff.
So at the end of the day, pain is this incredibly complex, entirely invisible alarm system. It's influenced by the physical firing of your nerves, the subjective numbers on a chart, the biases of the doctors treating you, and even the literal thoughts running through your head right now. So I want to leave you with this one thought to chew on. If our minds can create excruciating pain in a limb that doesn't even exist anymore, and if we can erase that pain using nothing but a mirror or a focused thought, Where exactly does the physical body end and the psychological mind begin? Thanks for joining me for this explainer. Keep questioning everything.